all of you. The Indian Association of Surgical Gastroenterology is honored to call upon Professor Pierre-Alain Clavien to deliver the prestigious Lucknow oration. Professor Clavien is the chairman of the Department of Surgery and Transplantation at the University of Zurich School, Switzerland. And I would like to call him to come up on the podium and take his seat, please. I'd also like to call upon Professor Avinash Supe, who is the President-elect Indian Association of Surgical Gastroenterology, to come up on the dais. Dr. Ashok Kumar, the current Secretary of the Indian Association of Surgical Gastroenterology. Professor S.P. Kaushik, the former head of Department of GI Surgery of Sanjay Gandhi Postgraduate Institute, and also the past President of Indian Association of Surgical Gastroenterology. Professor Kaushik, please. I'd like to call upon Professor Ashok Kumar to conduct the oration.
Thank you, Dr. Sujay. And first, I'll request Dr. Avinash Sube, the President-elect of ISG, to facilitate with the medallion. Now it's my humble privilege to introduce about the oration. This oration goes with the name of, as you know all, that is Lucknow oration. And the Department of Surgical Gastroenterology at the Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, under the stewardship of its present professor, first professor and head of department, Dr. Kaushik. I am very happy who is present here at this occasion, and he definitely, I am very, very happy and honored that, and he organized the 4th annual conference of ISG in 1994 in sponsor the Lucknow oration. Oration can be delivered by an authority in surgical gastroenterology, national and or international, at the annual conference of Indian Association of Surgical Gastroenterology. And the first oration was delivered in 1995 by Professor N.J. Ligdegakis. And the various orators are the 1995, as mentioned, Dr. N.J. Ligdegakis. In 1990, Professor Michael Hofsley, then Dr. Kaushik himself delivered in 1997. And subsequently in 1998 by McGregor from Edinburgh, in 1999 by Glenn Jamieson from Australia, in 2000 by Odd Sordy, and in 2001 by Toby England, 2002 by Takeshi Todoroki, 2003 by Dr. Irwin Benjamin, and 2004 by Dr. P.K. Datta, in 2005 by M. Rouge from Japan, 2006 by Chijiwa, Japan, and 2007 by Stewart, and 2008 by Fujita Hiroshima from Japan, 2009 by Dr. Nagino, 2010 by John Windsor, and 2011 by Lo Sim. And in 2013 by Dr. Yamamoto from Japan, 2015 by Regis from France, and 2017 were delivered by Hans Beger from Germany. And now I present Professor Pierre-Alain Clavien, University of Hospital, Zurich, Switzerland, to deliver this oration in 2019. I now request Dr. Sujay Pal to give a brief about the Professor Clavien.
Thank you, sir. Professor Clavien is a household word in the international group of surgeons. Wherever you go, it is almost assumed that everybody knows his name, because it's so closely associated with his a simple way of devising and classifying post-operative outcome, and the index that he developed, which is the Clavien index. And he subsequently refined this work and developed the composite complication index. And apart from all the work on the surgical outcomes that he has done, which we all know a bit about, some of his work is related to the preservation of organs, specifically liver, and a beautiful lecture that he delivered yesterday evening was a testimony to his work on that. Then he's worked on the ALPS operation, where the liver is partitioned, and in those patients who have poor reserve, we get a good outcome even after a major surgery. So these are the things that he works on, and these are the passion in the field of HPB surgery which drives him. But his initial work and his grounding in basic sciences began in Toronto after he completed his surgical training in Switzerland. Then he went on to United States, where he headed the Department of Transplantation in Durham, North Carolina, at the famous Duke's Hospital. And subsequently, he transferred to the Department of Surgery in Zurich, Switzerland, and he's been the chairman of surgery and transplantation at the Department of Surgery in Zurich since the last decade. It goes without saying that he is a surgical researcher par excellence. He has over 500 publications in reputed journals like the NEJM, Nature, and Annals of Surgery. He, in fact, is an associated editor of Annals of Surgery, as well as the Journal of Hepatology, and scores of other reputed journals in the field of gastroenterology and HPB surgery. He is continuing to currently work on liver preservation techniques, and he's also side-by-side developing newer modalities of assessing post-operative outcome. He is also an expert liver transplant surgeon, HPB surgeon, a biliary surgeon. You name it, he does it. He is truly a colossus in the field of HPB surgery, and we are truly honored to have him deliver this oration today, which is the 29th Indian Association of Surgical Gastroenterology National Meeting. He'll be delivering the Lucknow oration, and he'll be delivering the oration on newer developments in the complications of surgery. Professor Clavien, please come to the thing and deliver the oration. Thank you.
Oh no, that's not the first one. Sorry. Can I have this is not the first slide? Oh. I'm sorry, something. Yeah. Okay, sorry. So Dr. Sergio Paul, thank you so much for the kind introduction. Very kind, thank you so much. I would like also to thank Dr. Peuch Sani for the invitation here. It's a great honor to be here and to deliver this very special lecture. So what I will try the next 20 minutes, I think that I have here 25 minutes, is to go a little bit through the world of negative outcome and complications in the field of surgery. Number one, this is clearly a serious problem. This is a problem worldwide. Statistics are here to tell us that we must do a better job. 40% of general practitioners seems to do bad things to their patient. It is counted that about 134 million adverse events occurred in the world, which caused almost 3 million deaths. And the cost, for example, of error in medication, more difficult to judge for surgery, it's about 42 billion in the United States. So clearly we have to do it, and the society, whoever is looking at us, will really carefully make sure that we are doing something. So what I will try during this conference here is to speak about complication and the definition, the endpoints, talk a bit about a tool that we developed a few years ago called the Comprehensive Complication Index, and at the end, a novel way to compare our results. There are different ways, and I will just here suggest a way and to try to show you some of the advantage of that. Now, here, clearly, if we look at that, there is no consensus on the definition of complication, or very little. There is no standardization worldwide, even within a country, how we collect this complication. Information of the severity is rarely performed, and we do not know what the best achievable result when we have a procedure, we talk to patient, whether, what are the best results we can achieve for our procedures. So here I will start just to define 3 different negative events to make sure we focus and we understand on one. One is the sequel. That's clear if someone did an amputation for whatever reason and cannot walk, this is not a complication. It's a problem, but that's a sequel that's expected. If you treat a patient for cure, for cancer, and you have an R2 resection, we heard the previous speaker how important it is to go to R0 resection. Here, this is also not a complication. You just fail to do what you were planning to do. Everything else that could be considered as a complication. Now, if we look about our literature here, how good or how bad we are in talking about our problems. Follow-up information. Everybody knows if you look at your data, if you follow 1 day, 1 month, or a year, you would have different data. In fact, only 22% of the paper published, it's not better today, that's already some time ago, mention anything about the duration of the follow-up. The definition, what's a complication, only 1/3 of the paper will suggest what a complication is. How severe is the complication on one paper, on the 5th, will tell how severe is the complication. They would just give a name on this. And very importantly, of course, are the risk factors, and only 1/3 of the paper really comprehensively tell us about the risk factors. So when we show this data, of course, it's difficult to convince the world about what we are doing. Here, just another example, 2 studies here published about Whipple operation, one from Michael Trede from Germany, the early stage, many years ago. He reported 18% morbidity, complication. We did here with the Johns Hopkins group in 2006, 3 years review of the complication, and we found 60% complication. How can we compare one figure with the other one? Of course we cannot. For Dr. Trede, it was going back for surgery. For the work on the Johns Hopkins, it was just to use our new classification to detect everything. So of course, those figures you cannot compare, you can compare them. Even now today, if you look at fistula, many presentations about pancreatic surgery, so there is still several definitions of fistula. Even most will use the first one in the drain, but today many don't use drain anymore. Hard pancreas, no drain. So here again, we have a problem in defining our complication. Now the endpoints. I mean, for me, for the small country in Switzerland, our big city is Zurich. We have more than 500,000 people, and many people in Switzerland think this is a very busy city. Of course, if you're in this country, a big city has a complete different meaning that it is in another country. So we have a lack of objectivity when we look also at our result in surgery. Another example, many times you will have an incidence of pneumonia following whatever procedures. Do we talk about this and 5 days antibiotic and it's over? Do we talk about this, which may require intubation, or this patient who is a long term in the ICU? So very often, and that's easy to mislead, I will not say it's done on purpose, but sometimes it's not very clear. We have a lack of severity in grading our complication. So I go back to my time when I became a little bit interested in that. That's a long time ago. I was a fellow working in a laboratory in Toronto here, and that's the time when LabColle came on the market. And here, with the impression there was some bile duct injury, increased bile duct injury. So there was one simple question when the LabColle came: is it safe to do these procedures? And here we realize that there was not much way to compare one or the other one, and here with Steve Strasberg, who was my mentor in Toronto, a very well-known surgeon, HPB surgeon. We did a first attempt, we did a small classification to compare open versus laparoscopic cholecystectomy and try to answer the question, is really the morbidity higher than lower than that? I just make some quote here. I think this is research, is to see what everybody sees and to think what nobody has ever thought before. So very simple things, small classification to look at this. So we publish this paper. That's one of my first paper. I was working in the laboratory, but is some free time, so we were working on that. This did not work. Nobody was using this classification. It was 70 citation. Was that a wrong idea? It helped us to write a paper about lap open colectomy, but not much more. And here, our greatest weakness, I say this, lies in giving up. The most certain way to succeed is always to try shunt one more time. So this classification, we use it. From the 69 public citation, probably 20 were from us, but nobody was very enthusiastic. When I arrived in Zurich 10 years later, or 8 years later here, I asked one of the junior residents to look at that again, because we use it. We thought it was a good idea, and we revised this, and we came with a modified classification here, which was based on the degree. We wanted something that's objective, that it's easy to understand, and to look just as how invasive is the procedure to correct the complications. So we can compare that really from a patient and medical perspective from this. And that's the classification here. I heard that you're using that often in India, so this is 5 grade. I will not go through all the 5 grade. 1 is just minor changes, wound infect, etc. 2, you need some medication. 3, you need some intervention. And 4, you need organ failure, single or multiple organ failure, and 5 is death. So it's relatively easy. A student nurse can detect and fill up that. It can even be in a computer system, and that has had some use. People have used it up to today. We have more than 15,000 citations, and is used in many studies and now in database in the US and many other countries. So here it comes, nothing new. In 92, we have no better idea that we have in 2004. So nothing is stronger than an idea for which the time has come. At that time was the robot laparoscopy. There was maybe more needs to have some objective way to compare this. Here, just an example also from the same study at Johns Hopkins, how we could use this. So we have the grade of complication here, and here we have the different type of complication. So here, in a tabulated way, we can separate that and see the incidence of complication, and here say that delayed gastric emptying cause more problem than fistula, etc., by looking this kind of classification adjusted to the type of problems, and here you have the fistula also by severity. Now, when you do something, you want to evaluate this. So 5 years later, with other center, we wanted to check or to see whether it was good. In our morbidity mortality conference, there was a number of cases which was unclear. Is it 3? Is it 4? Is a complication? Is no complication? So we decided to look at this 5 years later, and here I would not go for time to many things, but we involved several centers. You can see that we use that, and we formulate scenarios that were unclear for us. In green is the agreement. In red was some disagreement here, so we have 89% agreement. We're pretty happy, and then we work a little bit on the few cases that were unclear. As an example, for example, a complication after a surgical procedure not caused by a surgeon, by a radiologist. Should we correct that or say it's not my fault? Since this is from the patient perspective, of course, it has to be recorded. And what do we do if we have the same complication that increase in severity? It started with a small pancreatitis, then we'll develop necrotizing pancreatitis. The suggestion was to go only to the most severe complications. So that was this study done 5 years later, but here this is a problem. And one of the problems is that we look only at the most serious complication and we ignore every other event, which seems not to be very smart to do so. Example, we have 2 patients who have different type of complication, who has the most serious outcome if we have to compare these 2 patients. So here I was part for a few years on a group of surgeons, statisticians. We met in Oxford a week every year. And then I asked the question to these very smart people in Oxford and scientists whether we could have a metric that will cover all complications, that we can simply do this. And the answer from the group was really, I think we cannot do it. It would be very difficult. We cannot do it. Well, I still gave this work to one of our fellow, Dr. Kameniak, who did a PhD. We did that in collaboration with the epidemiologists of Amsterdam. And basically the question is, can we validate or discover a system that integrate all complication and correct for the severity of complication? So we had already tools to go. One, we had our system. We can grade by complication. It was use, and then from which perspective, and we thought the most important is from the patient, because they are the one who suffer, and also from our side, because we're also involved in this perspective here. Nothing in medicine, but business is much more important, unfortunately, than medicine, patients, or whatever, and here they have this kind of formula called the Operation Risk Index, where they basically try to assess, taking into account many factors, what is the risk of putting money here or doing this here or that. So what we did here, that's what they do, they try to predict the general business climate using predictive criteria. So what we did what they have in finance and what they have in medicine. In finance, we have the stakeholder, the people who put money on the stock market. In medicine, with patients and physicians. And here we have the stakeholder. They need to estimate based on the political stability, unemployment, corruption. They have all these factors. In medicine, we have to base that on complication, severity, etc. They were using for the finance a score for 0 to 4. 0 is very bad corruption, 4 is perfect country. And for us, with the visual scale, we show patients and the doctors for 0 to 100, they could put that. And what we did here, for time I will not go, but we did a lot of scenarios, 30 different scenarios, that was in fact describing a degree of complications, and we presented that to doctors and patients, and then they were looking at that, and we did a lot of calculation to arrive to a specific formula. On the left side, this is the formula in the economy, and that comes this operative risk index as a value, and in medicine is a bit more complicated, and that goes to Dr. Puan, who is the epidemiologist. We work a lot together, with this formula, when we have the median reference value for physician, patients, and with this formula, we achieve basically that 0 is no complication and 100 is death. And we were convinced by this when we were looking at, for example, the weight of grade 1 complication based as how sick is the patient. And you can see here that if you increase the CCI, then the weight of a grade 1 complication decrease. That was intuitively correct, and I thought that was a good formula to do this. Now, if we go to this scenario here, where we have here different complications, the CCI will give us a value of 71. If we will only look at the more serious with 46, so we can see here that we capture something, and it's very different in this outcome. Let's go back to the two patients I presented you before. In this, one has a 3B, one has a 3 as the most severe, yet the most serious is the first one, because he has also other more serious complications. So certainly a new and valuable tool for that. Another advantage with this composite value is that we can calculate that over time, and you can see here that it can increase with different disease. So we got now a first look at how increase the morbidity for procedures. It's used by some people here. Dr. Yang in Korea, a very well-known gastric surgeon, who told me he's using that for every surgeon. If it's a good idea, I don't know. So everybody has their CCI or the department to see how they are doing. Now I come to the next topic here is how can we compare the procedures, centers, surgeons, whatever in that with the tool of complication or CCI. And you have patient center with this course and different course. How do we compare one with the other one? And here, how do we calculate this gap? And it comes to a new concept. The word is not new, but the way to do it is a bit new, is benchmarking. And benchmarking is not average. Benchmarking, it's basically what is best on the market. So a few years ago, for the cell phone, it was clear which one they came, and the other one had to compete with this one. In tennis in my country, this is our benchmark. In surgery, there are not only one best. That will never work. In surgery, we need to compare to best centers in the world with different factors to do that. So the benchmarking first was to identify the way we will proceed. I showed a study, we did that, the best achievable results. So we want expert centers here, usually with high volume, patient selection. Here we select only the low-risk patients to compare these. We have to define a follow-up, of course, and we have to have good indicator what we want to measure. So the indicator must be relevant, standardized, that we can reproduce, and of course that you can improve. Otherwise, it's just a useless exercise in this setting. So the endpoints are relatively, could be in use of intensive care unit, blood, the need for intensive care, mortality certainly, and the morbidity. We're using our classification or this CCI, the Comprehensive Complication Index, for this. Now, how do we do that? We take several institutions that qualify as center of experience, and here, for example, you have different CCI value for the same procedure in low-risk patients. So how do we define the benchmark value? That will be the median for these centers. That will be the confidence interval, and we decided, in fact, to use the 75 percentile of the median of the center as the benchmark value, which will mean high-quality surgery or medicine in that center. I showed two examples of studies that were published relatively recently. First is the one in liver transplantation. You can see many authors here. It was 17 centers for a 5 years period on 3 continents. We took the largest center per country, more than 50 livers, well-defined low-risk cases here, and we identify low-risk was low MELD, was no retransplant, etc., and we identify about 2,500 benchmark cases. The total is about 8,000, so benchmarks, so these low risk, are done in about 25% of the case in this center. First of all, we could see, looking at the CCI, that morbidity in liver transplant increased significantly over 1 year. First conclusion, if you want to report a liver transplant, you should probably report 1 year. 1 month, 3 months is not enough. As you can see, the dramatic increase between 3 months and 1 year. Now, if we look here at the data, I would just show you the data. The surgery was less than 6 hours, less than 3 units of blood, 4 days in the ICU, 18 days in the hospital. That was the benchmark value for low risk and so-called good cases. Now it came here from the US to say this is dangerous because you showed the best result. How will that be a problem when you operate more risky patient with problem with patient or insurance company? So it come here with the questions that we want how to use this. Is that really useful? So here I just show you some example also how to use this here. This is here the center. They are of course anonymous here, and you can see as example the difference of benchmark cases. So one has 8% of benchmark, so they operate mostly difficult cases, while the other one has 50%. So very different. For the first time, we can very quickly identify which center take risk in operating patient, or they just do the so-called easy cases. Maybe they don't have the referral for that. So that identified this. Next, we have the outliers. If here we have independent center with a CCI, we can see that those that above the benchmark may need to have a review. The other one don't need any review. What we are doing in our center for every patient who has a CCI above, what we expect is discussed in the mortality morbidity conference. Often they are not benchmark cases, they are higher risk cases, but at least they are discussed all these cases. I finish here by showing a recent paper that we published on pancreatic surgery. Here was also 23 centers, so many centers. You can see in Asia and North America and Europe, so many of the large centers accept to participate, which was very good. We were looking at Whipple, low-risk Whipple here, so no arterial invasion, no previous surgery, etc., no major comorbidity, so the good cases here. And here again, we identify about 2,000 cases out of 6,500. So here again, about 25% of the case qualify for benchmark. The other are higher risk cases. Result here, surgery less than 7 hours, no blood transfusion, 1 day in the ICU, 15 days in the hospital. That's the benchmark values for these different markers. Here, when we were looking here at fistula, for example, here we have less than 18% fistula in these patients. Again, if we look per center here, we have an interesting observation here that I would finish with this. You have two centers with the same volume, which were qualified as good centers. One of these centers has 12% of benchmark cases, so they do mostly difficult case, while the other one has 72%. And you look at the fistula rate in these centers, it's an observation, we found that the one who do difficult cases, and much less fistula, severe fistula, than the one who do mostly easy cases. And here it's a bit the learning curve effect in this, and I will come back with the next slide on this. We also found, and we have another center here, which is the largest center in numbers, with do mostly difficult cases. They have 6% fistula here, so more than the smaller center who also do mostly difficult cases here, and that probably, and I will show you a graph to maybe better highlight what I mean with this. We also found here was a conversation before, that was 3 centers, so it's not definitive data, but in benchmark cases, the results were not as good in minimally invasive surgery that it is for open surgery. All these cases were done on open surgery. So it's certainly not a definitive, but you say we have to be careful looking at that. So that's the last graph I would like to show here about this important and discuss outcome versus volume cases. So clearly we may have here this curve. This is here the learning curve that we have here, reaching here a plateau. Let's say 60 cases, then you have reached the best you can do based on this. And then after some time, there is a breakdown. Now we observe that in France, in the US, after a very large number, result go down. There's many explanations for this, but this is something we have to be very careful, whether it's a referral, waiting time, less attention, but this is something that we have seen, and this benchmark study also suggests the same observation. We can now also, with this benchmark, compare procedures. How could we compare esophagectomy with a living donor, liver transplant, pancreas, or ALPS? And here we have the best cases from each groups, and we can compare here the different. That has an interest in cost and reimbursement, informed consent, so this is not without value. And we can see here, for example, we're looking at the ALPS mortality here is 4%, or is higher than the other one, the higher complications in liver transplant, but we can see here all these studies were done with the same methodology, multicentric, and involving low-risk cases. So I come with the take-home message from this presentation. I think we still need today standardization in outcome endpoints. We see still many studies, very nice study, but it's difficult to understand the endpoints. We need, I think, to use by severity and no longer speak about pneumonia and without telling what that is. We believe that the CCI is a new tool, not the only tool. I don't have time to say when we should use what, but this is one tool that indicates overall morbidity. You still need to dig to understand what type of morbidity you have. And the follow-up, importantly, we need to be serious with the follow-up in reporting that. I had not time to show, but the CCI help also with costs. There was a study done that correlates with costs, which help us, surgeons, to have a quick look at the cost of the procedures versus what the administration gave us. So we like this though. We have a benchmarking here, so we can now also from this see gaps between center, in our center, so that's a nice tool to monitor the quality we are doing. And the goal, of course, is to increase the efficacy and decrease complication in our patients. This work was done by these people, and I think also in research or whatever, it happened when 2 or 3 people together are on the same line and work. Milo Puan, who trained at Johns Hopkins, came to us. He's the head of epidemiology. We have many discussions, and we always search what the other one to mean, and that's why we're very clinically relevant and not this formula that we cannot use. And below are all people who did a PhD or work on complication or benchmark in my center. Thank you very much for this honor. Thank you.
I'll invite Professor Soupe to give a vote of thanks and conduct the presentation ceremony thereafter.
Thank you, Professor Clavien. I think it was a pleasure to listen to you. An excellent talk on how he really developed the Clavien Indo score. I think in this hall since morning, we must have heard in every presentation his name. I think that's really the honor. And he also helped us, he told us about how he developed now the new score of CCI and benchmarking. It's really an honor to listen to you. And on behalf of the ISG, we would like to really honor you. Please.
We will now break for the lunch session, and the poster session will be conducted simultaneously in the dissection hall. We will reconvene here for the special mention poster session.